morning to those of you, or afternoon now. Sorry, I'm so behind with the time, but welcome to those of you that are joining us. There's loads of people are still just coming in on there that I can see. So I'm sort of doing a very slow introduction there while people catch up and Zoom catches up. And if it's anything like me, you've had to do Zoom updates and goodness knows what to get in. So well done, you've made the first hurdle. So welcome to our Yorkshire and Humber branch meeting today for IIRSM, and it's one that I've been looking forward to since we got a confirmation that Matt would be joining us. Matt is he's a principal ergonomist for the HSE's science division. That sounds very cool. He is going to be taking the strain out of MSD risk management for us. So he's going to be looking at what we can assess, the tools we can use, when we need to do that, bit of background on what the HSE might be focusing on and risk reduction approaches that we might take as well. So he's got an awful lot to cover. And with that in mind, I'm not going to witter on at you for too much longer. What I am going to say is if you do have any questions that you want to put to Matt, if you just stick them in the Q&A box or chat as a last case resort there, I'll be monitoring those and we'll put those on, we'll give those to Matt at the end of the session and he can answer those for us whilst we're still here. So without further ado, Matt, I will hand over to you and let you take us through this quite interesting topic. So thank you.
Thanks, Heather. Thank you very much, and good afternoon from me too. Thank you for joining me. Without you guys, this is just me talking to myself again. So very much appreciated, and thanks for spending some of your hopefully lunchtime on this topic, which is very dear to my heart. If you've ever met me before or seen me talk, it's nearly always on musculoskeletal disorders. And on the one hand, there's nothing new under the sun here. But on the other hand, there's been quite a lot of things that have been up to in HSE that I wanted to make you aware of and spend this opportunity to let you see some of the new stuff, which is, we're very grateful that we all pay taxes and it's all yours. So I want to encourage you by signposting to various bits and pieces. If you think it's interesting, please do go away and obviously spoil your own weekends by reading up on it and having a go. And to that end, I'm going to show you a few of the slides where I forgot what they're called, the QR codes type things, to just give you some of the kind of signposts to bits of website and internet where some of these things are. So grab a smartphone if you've got one. Don't worry if not. I think we share these slides. At the end of it, I'll show you a slide where you can do a quick screen grab to get all the QR codes for all the things I'm about to show you. So thank you very much indeed. If we've not met, thanks Heather for the intro. I'm Matt and I work for HSE and Science Division. It sounds cool, doesn't it? We're about 400 science specialists. Some call us nerds, but that's unfair. 400 nerds. My particular area of expertise is musculoskeletal disorders. So let's have a look. First and foremost, I suppose, and if anybody's been on a NEBOSH training course, they always do this. Why should we be engaged in MSDs? Why be proactive? Why am I here talking to you guys for a bit? There's always the three arguments, the legal, the moral, and the financial arguments. And they're the ones that we take to senior leadership teams to ask them to give us a blank check so we can intervene on behalf of the workforce to manage risk. And there's just something to make you aware of on this kind of virtuous triangle. On the legal side, now I appreciate HSE as regulators, we're not the only part of legal motivations for being proactive. And we've got claims mitigations and that side of legal equation as well. But on our side, I don't know if you spend a lot of time on the HSE website. If it's with a new version of the website, it's probably looking for stuff, to be honest. But just published 3-4 days ago is our HSE business plan for next financial year. And in that, as I've grabbed from that, we will reduce work-related ill health through a proactive inspection campaign. Our inspectors are queued up and they're ready to go. And so far this year, we've had in the world of MSDs, around 1,500 inspections. Next year, we'll be having a few more. In total, looking at all health, 4,500 inspections is what we're promising the UK taxpayer. It says there's an expected enforcement range of about 40 to 60%. So of all of those inspections that we're planning, 4,500, it'll be about 1,500 to maybe 2,000 of those will focus on MSDs. And I don't know about the expected enforcement range. That's genuinely made up. We're at the moment getting 15% of inspections are finding breaches, which result in predominantly knocks. You won't know what that is, but a notice of contravention, a letter, and of course that incurs fees for intervention costs. So it's just a fair warning. Please take it from me, but do also read it in black and white. It's what we're committing to do next year. With musculoskeletal disorders and health in general, there haven't been a focus on inspections for many years. And fair warning, this year, sure, but certainly next year and for the next 3 or 4 years, there will be a focus, which makes this pertinent, hopefully. And so I was going to talk about how you go about managing MSDs. And I've stolen this from Upper Limb Disorders in the Workplace, an HSG 60 it's called. It's one of our books that's freely available online. Once again, have a terrible weekend looking at all our stuff. Of all the things written on MSDs, this is maybe the smartest we've done. I didn't write it, or we didn't write it in this building, so I'm allowed to say that. I would highly recommend it to you. It's about upper limb disorders, but you could replace that with lower back pain and lower limb pain even, and it's still as pertinent and as useful. And the chapter headings in that book are what we're going to very briefly run through now, which this list on the right-hand side gives us the A through Z, the start to finish of managing musculoskeletal disorders. And that's what I was going to use as my stepping stones to show you a few new things that we've got going through or have gone through, and I'd like you to start using them if you reckon. So the first one of these is understanding what are the issues with MSDs and with health in general and committing to doing something. Well, you guys are already winning. You've spent an hour of your lunch times with me on this forum, and this is what it's all about, is understanding where the issues are, understanding what you're going to do about them, and making that commitment. And to understand the issues in HSC and in ergonomics, we're huge advocates of engagement. Have a chat with the workforce, and that 9 times out of 10, if you don't mind it, is a cup of tea and a packet of hobnobs and a sit down with the workforce and say, you know, what's going on, what's up, how are you, and those kind of things. Let them tell you what's happening in the workplace. But we've got a slightly new system on that that's a bit more formal approach to it, which is a free download for you guys to use, called the body mapping tool. I'll give you links to this in just a second. It's a way of doing that very thing, sitting down with a cup of tea, but instead of hobnobs or the biscuits are available, of course, what you can do with this tool is ask the workers just to literally put a dot on a body map. Do you get any aches and pains? Whereabouts are they? Put a dot on this map for me. And you put this map on the wall, maybe as a A3 poster or something, grab yourself some marker pens or stickers. And then you can do things like, red pen for recurrent kind of progressive pain, or a blue pen for transient. You just banged it or just hurt for a short while, or severity you can measure. And all this does is shows commonality across the workforce. You can do this with different, say, manufacturing lines or areas or groups or tasks, and find out where those common areas are. Now, a lot of this probably won't be news to you. You'll have an inkling that this has got a lot of manual handling, bad backs here. This one's got lots of packaging operations at the end of a line. We often get, upper limbs issues there. But it's a way of classifying that and measuring it and discussing it with the workers. Once you've got the body map up and running, few dots all on your right shoulder, for example, you can then start a conversation with the workforce saying, why is there so many dots on your right shoulder? Does anybody think about what task that might be aligned with, or what day that's happening, or is it specific to it? It's a really, really good way of engaging in a semi-formal way to start to narrow down where you start taking action, where you actually begin your process of, trying to understand the task by assessment and then hopefully reduction. So how they commend it to you, I'm only showing you a small part of it. There are 3 documents in the body mapping. This one, which is the map itself, there's another document that if you're not used to facilitated sessions, there's the instructions how about go about doing that. Some of our psychologists wrote that. And then there's some posters, so you can capture the vibe in the room, print out some posters and put them around. That becomes then the body mapping room that you could use a tea break room or anywhere that you've got available in the workplace. So I commend it to you. Go and have a squiz. If you do have a look at it, you will be asked who you are. That's purely so that this is a beta version. At some point in the next 6 months, you will get an email to say, did you give it a go? What did you think? That's the only reason we'll use your contact details, is to try and gather feedback, because it's a brand new beta version. We want to see if it works for you, see where we might improve it and so forth. So don't be put off. Otherwise, just give a false name. It doesn't really matter. Have at it. I hope it's useful to you. That's the link to it. If you've got a smartphone, that's the link also on the barcode there. But again, I'll be sharing all these after the fact, so feel free to look at these at your leisure. So the next stage of this, once you've started to narrow down and understand what the issues are and decide you're going to do something about it, it's creating the right organizational environment, looking at the safety culture. Now, I'm sure you've all been on safety culture training. I'm not going to go into that, partly because it's not my technical area. But it often gets aligned with an iceberg model, where you've got the climate above, the things you can see, touch and feel, and take a snapshot of. And that's all affected by the culture. And that's, epitomized by that saying there, the way we do things when nobody's watching, and looking at the cultural influence on people's behaviors. So there's lots you can go into that. Look, once you're in a weekend with the stuff I'm about to comment to you, have a look at safety culture and sit back and enjoy the ride. But in MSDs, it tends to be, we have, and this is what I want to try and get you to appreciate, is we tend to engage workers and we focus on engaging the workers. It's really, really important that we engage with the workforce. They provide you the insights as to the task, and they know all the things that happen when you're not watching. You get that positive uptake of any new interventions and new ways of working. It's not your idea as a hugely successful global safety manager. It's their idea. Trevor, who works next to them on the lines, and so it really helps that change management. Helps you get things right more often you get things wrong, which is a fantastic way of going about this, but we'll never get the money to spend on new interventions unless we also have the senior leadership involved. We need that photograph of your senior most leader with their arm around you saying, yeah, we are supporting this initiative. We have to have that senior leadership, that agency they provide, and the money they provide. It's every chance that they've got the checkbook. And so enough said on that. I think it's about having a top-down and bottom-up approach at the same time. Getting the senior leaders, these engagement and funding, and then engaging the workers to find out what's really going on and sort out the difference between workers perceived and workers done. We then get on to the main gig of the things that we provide from HSE, and that's the mechanisms for assessment and looking at these risk assessment methods. And I imagine, hopefully, be interested to know if otherwise, but most people will be familiar by now for the RAP and the MAC for manual handling and the ART tool for upper limb disorders. Nothing's changed here. We are currently reviewing the MAC tool. We're currently reviewing the RAP tool, the pushing and pulling risk assessment. We're going to try and tighten that up a little bit and look at specifically what happens when you get quite heavy loads, like, 650 kilos on a roll cage, which is milk delivery, but then you put that on a ramp that's more than 5 degrees, which can happen on access into buildings. There, we think that the RAP tool underscores risk a little bit. And so we're looking at that, and the evidence base is now being gathered mid-December. We'll have the evidence base, and then we'll look at the tool and redesign it a little bit. The Mac and the art tool, nothing's due to change on those. They've already changed over the years a few times. Just to let you know, though, that with any changes in any of these tools, it's really important that you don't feel you have to go and reassess everything. We're trying really hard to make risk assessments less paperwork for you and not more paperwork. So just because we change a few nuances of the risk factors in these tools, please don't go and reassess everything unless you love doing risk assessments or you're getting paid by the hour. Instead, stay with your assessments when they come to review. That could be annual, biannual, or when there's significant change, or post, God forbid, but post incident. When you come to review assessments, then introduce the newest version of the assessment is all. So watch out for the RAP tool. There'll be a bit of noise, probably early next financial year on the new version of the RAP. And all of these tools, hopefully you've found by now that TSO Books, our publishers, have put them all online that work just like an app. If you've not found them, there's a link if you've got a smartphone at the ready. But I'll again reshare that link to these in just at the end of this presentation. But they're all online and they work almost like an app. There is a paid for version that is an app. It works like an app, but for most of us, there's no need to pay for anything here at all for free. It just means you need internet connection to do your assessments and then send them to yourself. How they work, just in case, I don't know if anyone's familiar. I'm assuming people are familiar, but look, I don't get out of bed unless it's a Mac demonstration. So I'll do you a very quick Mac demonstration of this task. You can see it's just a picture. I'm not going to show a video. These two lads are lifting and carrying this heavy lump. Not sure what's in there. It looks hollow to me. But if we were to do a quick assessment of that using the Mac tool, it would first and foremost, it will be a team lift. There's more than one person involved, so we go for a team lift. If it's one person just lifting it or putting it down, it's a lift assessment. If, though, that person moves more than 2 meters, then that will be a carry assessment. And so whenever you're picking something up and carrying it more than 2 meters, you'll probably do a lifting and a carrying assessment. In this case, though, it's the team handling, so it'll be a team assessment. And now, just in case you're not familiar, the Mac's going to score everything under a traffic light system. The only one that's not in a traffic light is purple, where things are very heavy. To just give you some interpretation, whenever you get a purple with these tools in the Mac tool, that is really sort of suggesting to your inspector colleague that that's probably a prohibition notice. So watch out if you are lifting in that purple zone. It's likely the inspector's thinking, okay, this is probably a prohibition notice unless there are other mitigating factors. So do stay away from the purple zone. It's too heavy for those number of people to be lifting. In this case, though, it's 40 kilos, and 40 kilos on all these for 2 people scores in the amber zone. So for that risk factor, we just forget about it for now and carry on through the tool, which I'm not about to do the whole tool. I'll just do a few examples of these. We then get into posture and neutral posture or non-neutral postures. The further the compromise away from neutral, especially during force application, the greater the level of risk. It just puts more leverage on the joints of the body, a bit more likely to create an injury. So in this case, the guy at the back there in that image is leaning over a bit, and certainly the both of them, it's their arms that are elevated away from their body. It's probably best described here, hands are, or upper arms are angled away from the torso, perhaps. It could be into the red for the guy at the back, maybe, if it wasn't just a picture and it wasn't just after lunchtime. And so on and so forth. Once again, vertical lifting, how high are they lifting it to? Well, it's going to stay at waist height. Nicely simple green one for that. And you're looking more and more detail at each of these risk factors. This is grip on load. And if we look at their grip on the picture, probably described as lack of finger clearance or fingers supporting the load, which, yeah, it might be the case there. Where it's not a picture of me, look more closely. How far are they going? Just fun with maths and so on and so forth. And the idea of the tools is you go all the way through each of these risk factors, green, amber, reds, and on the online version, this is what it looks like. Here, all it's indicating is we don't really know what that job is, but immediately there's a high risk red risk factor. And if we were to start fixing that job, that's the thing we start to fix sooner than anything else. That's our priority. And in this case, Hans back, it may well be because it's reaching farther away. Maybe I captured that then. So what we could do to that is make the table smaller, so it doesn't have to reach over the table at the back there, or just try and get that posture improved. So ideally, the red becomes a green, maybe, and then look at it. There's try and get those ambers down to green if you can. You can't, and it's okay to live with reds. But do be wary if ever the load weight is red. A lot of, in terms of our regulatory colleagues, one thing they're looking for is load weights. And if ever the load weight is red and you've got other reds in any of these risk factors, there's a greater chance that you're into kind of enforcement territory, perhaps a knock, a notice of contravention, perhaps an improvement notice even. So watch out when things are heavy, it raises the stakes on the outcomes of the tool. If you're using the online version, all this is for free. You just email it to yourself and then it rocks up into your email just like this. Can I just give you an assurance that HSE will never read your emails? Life's too short and our IT isn't nearly good enough. If you use this tool to email yourself, that's entirely your information. We will never read that for ethical reasons as well as IT reasons. It's a miracle we've had Zoom working for 25 minutes now, nothing's gone wrong. So please be assured that we'll never be looking at your emails if you do email yourself. And there's lots of these tools. That's the wrap and the art. And that's also under books.hg.gov. Our TSO is our publishers here. There's also the body mapping tool there. There's also the bird tool, which is quite new on the block. The bird tool is for back injury risk for drivers. If you've got any form of vehicle driving, whether it's on the roads, on the waterways, agricultural or forestry or in mines, any vehicle driving, the bird tool can help you discern what the key risk factors are. Works with fleet vehicles all the way up to speedboats. Now, it's not in itself a risk assessment. It's just a very quick way of identifying the key risk factors so you can focus on those with your risk assessment. So if you're not familiar with the bird tool, there's a link to them all. Again, links will be provided later on. But have a look at what you can find. There's lots and lots of stuff for free there as we move and transition more from a paper-based onto an online version of our risk assessment tools and guidance. I don't know if you guys can hear, but someone's trying to break through the walls here. I'm not in any danger, but if you hear knocking, I do apologise. There's some excitement somewhere else in the building. I'm currently in HSE Buxton. So we understand what's going on by hopefully talking with the workers, maybe using the body mapping. We then make sure that organisationally we've got things set up, senior leadership engagement, so that they can, facilitate and help and support these. Otherwise, you'll never get anything changed. But the workers' engagement as well to understand what's really going on. We then can assess the risks of MSDs, and then this is where the rubber actually hits the road. This is where we make a difference, is reducing the risk of MSDs, trying to engineer the risk out. And this is where we're doing some upcoming work. At the moment, actually, there's a new research project trying to update some guidance for you guys on this. I think this is where we have a significant challenge because nobody knows what fit for purpose actually looks like. For one organisation, it'll be different than for another. So what we've done is produced a few guidelines on this. This is just solutions you can, best use of manual handling solutions. And there's lots of those in there, maybe arguably not enough. But the kind of things that you might be seeing is, some powered trucks at the top there, some wheeled items from a trolley up to a pallet truck and so forth. And then more sort of manipulation stuff, high turntable tables or pallets, pallet piles or rotatory pallet tables, things like that. Just gives you some idea, but it's a line drawing. It is slightly limited, I'll be perfectly honest. And so what we're having to do is send you guys back to, in some circumstances, the oldest one is 1996, believe it or not. The top left there is just some of our MSD resources for good practices. So when you're looking at what can we do for risk reduction, absolutely follow the traffic light systems or the tools, but as well, just to see what other people are doing, what's fit for purpose, or what, was cost effective. In one case, only one of them goes back to 1996. A lot of these are about 2014, which isn't new, but I'll talk about it in a second. But there in the link on the top left of our website are good practice guides for all of those sectors. So these are musculoskeletal disorder, good practice guides for reducing the risk in these sectors. As I've mentioned, they're not all brand spanking new. And so at the bottom there, and that's where you've got the link if you've got your smartphone out. If you are using your smartphone to chase all these down, I do apologize, it's going to mess up your search history, something chronic. But that's from Washington State over in the United States. We found this resource, it's a database of other ideas that we really like. I think it's kind of useful. You can search by sector, so you can say I'm in the construction sector, this is block handling, and it'll just show you a few of the examples of solutions to help with that sort of a task. And the bottom one, that's from Washington State, that's what we're working on now. We're putting all the paperwork together to start off the project. That's what we're hoping to have in HSC very, very shortly. For us, that's about 6 months, by the way. A database of just all the good practice materials we've put together that's not gone out of date, that's still common practice in industry. And then we'll be gathering a lot more new good practice materials, including things that are more powered and battery operated, like the battery operated tugs or the various lifters, stair climbers, and things like that you can get. So we'll try and get as much information out there as possible to you so that you've got half a chance of understanding, the kinds of risk reduction methods that are out there. Because this is where it becomes very important. This is where you can walk away from the job knowing that you've changed the operation. And if you can engineer out risk, it's engineered out forever. So the job will never be quite as high a risk as it was before you showed up and intervened. So we're very much advocates of risk reduction, and we think it's a very significant way forwards. And in fact, I don't know if you're familiar with this, but every year we run a competition, Risk Reduction Through Design Awards, with our colleagues over in the Chartered Institute for Economics Human Factors, whom I belong to. HSE and CIHF run this award where we ask you to, if you had a good idea, put it into place and take some photos of it, send it in, and there's a judging panel. We've currently got about 25 entrants for this year. It closes in January next year. And some HSE colleagues look at it, some Chartered Institute of Economics Human Factors people look at it, and then there's an award ceremony at some point, around about end of March, early April it'll be, where you get to wear a black tie and somebody you've never met before shakes your hand. But more importantly, you get published on the HSE website as one of these good practices, and you get a little trophy of some kind, so you can put that in your reception. And hopefully that will be very disarming to any of your supply chain or HSE inspector going maybe when they walk into your organization, see you've won something. So it's all very LinkedIn-tastic, very, very good for the organization, but very good for us in HSE to be able to promote those good ideas and share them with the UK. And so some of our good practice guides will be coming from that kind of initiative as well. Is that okay so far? I'm halfway through. It seems like a half decent place. Let's see if anyone's still there. You can either give us a thumbs up, or and if you can make any other gestures or any questions so far. We'll give Heather a run for a money. Anything that's worth stopping.
we've had a couple of questions so far, so I think and I've been jotting down just as many things as I hope everybody else has been as well. But one of the first questions that came through was, what specific methods or tools do you recommend for proactively identifying the early signs of MSD risk factors in the workplace? So I think you've talked about some of the tools there. Is there anything else that you could think to proactively identify the early signs?
Yeah, it's a really good question because lagging indicators, so gross, aren't they? And by the time you get to a lagging indicator, someone's gone off, or God forbid, worse, there's already blood on the ground, proverbially, hopefully. And so the body mapping, obviously, first thing I mentioned, and I must say for the body mapping, we stole that really good idea from USDOR, the colleagues over in USDOR, the union. So it's not a novel idea. They've been doing this for years. The one that we had ahead of that, if you do look at body mapping on the HU website, you might still find this, or any search for the Nordic Musculoskeletal Questionnaire, the NMQ. And the Nordic Musculoskeletal Questionnaire, or NMQ, is another body map, but it creates 9 body regions from head to toe. And we use it a lot in research because it's so sensitive. It doesn't look at aches or pains or injuries. It looks at discomfort. And it says, have you had any discomfort in one of these 9 body regions? And it does a couple of things. It asks you in the last 6 months or maybe 3 months. So you're getting a period prevalence. And also, how about now? Do you have any issues now? So you get a point prevalence. The reason it's so cool is it's what everybody in research uses. We've used it myriad of times now in different sectors, all of which are published on the HU website in research reports and things. So if you ever wanted to look at, say, your organization and benchmark it against other organizations, some good, some bad, and it's a big range of organizations that have used it, you can end up saying things like, I'm making this up entirely, so no harm or foul to any of these sectors, but hey, we're slightly better than nursing and care, but we're not nearly as good as motor vehicle manufacturing. You can sort of gauge things, and there's lots of construction and brickworking and things like that, where they inevitably have higher rates. And there's even a care homes that have low rates, believe it or not, and everything in between. So that's very proactive. Because it looks at the sensitive measure of discomfort, not disorder, and that's the Nordic Musculoskeletal Questionnaire, which it's been around since 1988, published by a person called Karinka, but don't try and spell that. If you did the NMQ or Nordic Musculoskeletal Questionnaire, you'll find it on Google, I assure you, and also on our website.
Oh, that's brilliant, Matt. Thank you. I wrote that down as well. And there was one other question as well, which was about the key metrics or KPIs, which you talked a bit there, or didn't you, on the lagging indicators? And which one, as been asked, would you suggest for tracking the effectiveness of MSD risk management interventions over time as well?
Good question.
That is a question, isn't it?
Yeah. So there's a couple of ways of going at the micro and the macro, I suppose. The micro is easy to answer, pre and post intervention assessments. So on the micro level, task by task or line by line, as in construction line, manufacturing line, or site, or if it's construction or whatever. If it's micro, I would use the HC tools as semi-useless as they all are. They all provide you with a risk score, and we don't really have much trouble with the risk scores. Health and numbers don't go together very well at all. There's a whole bunch of fallacies that make us believe that if you eat 5 a day, eat 5 to stay alive, or you do 10,000 steps, it's all a load of rubbish. Please don't drink more than 1 unit if you're driving. We'll stick with that one, shall we? But how many cigarettes can you smoke before you start coughing? We don't know. It's health, and that's variable for all of us. So the numbers in the tools don't give you much indication of overall risk, but what they do give you is a risk score, and you can do a sort of pre and post intervention. Do a MAC tool before, improve the job, do a mat tool afterwards, your numbers have gone down a bit. So that works on that level. If I were doing an organizational pre and post intervention for musculoskeletal disorders, I would actually use the NMQ, which makes my life easier because I've said the same thing twice now. But I would use a Nordic musculoskeletal questionnaire. And indeed, that's what we do use when we're doing these larger scale, organizational scale interventions. Get as many. Now, the Nordic musculoskeletal questionnaire, the other thing you need to know about it is it works extremely accurately if you get 80% respondents. So send it out to a cohort of 200 people, and if you get 160 filled questionnaires back, it's going to be really accurate results. I would use that pre and post intervention, and then maybe on an annual basis as part of your well-being surveys and things like that, just to keep a track on where things are going. You can also use some of the demographics, so look at different lines or different areas or different task groups and see that, oh wow, the fitters are doing fine, but the painters are really struggling. It'll help you focus on things like that. So on a more macro organizational level, I'd still stick with that one, I'm afraid. It's not as exciting, maybe. You don't get a colourful dashboard, but there's a reason it's been around for now 45 years. It's very, very good.
No, that's brilliant. I do have another question that's just coming from Martin, but looking at your presentation, I feel you might still be about to answer that. So I'm just going to hang fire with that one because it's about training and educating, and I see that's next on your list. So we will come back to those questions.
Well, I'll carry on, but heckle me if I've not covered it in training, because I'm going to say, well, I don't know. Training's quite, let's go there. Training is quite a challenging one because HSE have been very rude about manual handling training in particular. We don't have anything to say on upper limb disorders training. There is in HSG 60, that yellow book, as first slide, there's some good stuff on that. If you're using training to help intervene on upper limb disorders, that's the yellow book. That's got a good outline of things you should cover. But for manual handling training, about 6 years ago, a colleague in policy was very rude about it, and it led to these sorts of headlines, which I've stolen off the internet. There's a problem with training in that it's obviously the end of the hierarchy controls for manual handling training. And this was born at a time, and HSE saying rude things at a time where two things were happening. First of all, there were three kind of evidence reviews, one Cochrane review, one meta-analysis, and one rapid evidence assessment. So different ways of reading evidence. And none of them showed that manual handling training was effective. And that's what led to these. None of them showed that manual handling training reduces the prevalence rates of musculoskeletal disorders. So we have the headlines like that. The problem with these headlines is I don't believe them. I think they're a bit of a fallacy. When we say that no science showed that manual handling training was effective, we're saying maybe one or two things. We're either saying that manual handling training is rubbish, which is what this interpretation is, or we're saying that the science is rubbish and it's lacking in the ability to look at something like that. And I think we've got to really be a bit more balanced on this, because manual handling training, you've got to do it. And it's really important. It's one of the most transferable skills you can give a workforce. If I'm moving house, I will use my manual handling training I got from work. Where I work in HSC, I'll also use a pallet truck, a sack barrow maybe that I've stolen from work, because they'll let me. You might not let people take equipment home with them. So often, if they're doing manual handling in their private lives, the only thing they're giving them is training and education. And so it actually is important. There are issues with training. Don't get me started. I could talk about it for way too long. I'll see how we get on with the question at the end of this and fill the time with the whole sermon on training. But I do think, as rude as we've been in the past, training is a necessity. It's very important. It's also a legal requirement. So you're going to have to do it. So do it well. Training can never overcome crappy jobs. If you've got a high risk job, training is not going to help. People are exposed to risk still, they're going to get injured still. So things like lack of mechanical aids, rubbish loads, poor working conditions resulting in poor postures, training is not really going to help. What training should be at is showing people better ways of doing things that changes their behavior when they do those things. It needs, well, let's see where the notes go. It needs to be specific to the organization and to the tasks. So it should cover what the risk factors that that workforce are being exposed to and how they could lead to injuries. I don't know if you know, but in claims mitigation now, it's not enough to say, careful, that knife is sharp. We also need to say, and you could cut yourself. Not our rules, but that's what we need to do. So what are the risk factors in that workplace, in those tasks? So it has to be task specific. What are the good handling techniques? We've got lots of sort of stuff on that. 20 years ago, we put together the 11 key principles for good handling techniques. We didn't write it. We had all the professionals in the country do a Delphi exercise. They wrote it, and there's no reason to have changed them. They're standing well whenever we get reviewed. Training should look at the actual appropriate or safe operating systems or appropriate systems of work for the tasks being done. And so some element of the training should occur in the workplace with the work tools doing the work jobs. Not all of it, because if you're on a production line, it's noisy and, you know, things are in the way. But that's where we should be practicing our techniques, showing our workers how to do that with their tools in their workplace so they can build up those good habits during the training course. And also, what you should also cover, if you're using pallet trucks, show people what that clicky handle does. If you're using roll cages, show people how to put the roll cage together properly. If you're using mechanical aids, that needs covering in the training room, just so that people can play around with it before we're going to put a half a ton load on it and then all the mates are watching. And then, you know, I've already mentioned this really, but yeah, there are books and there's e-learning, there's all kinds of stuff you can do for training. It's all nice to begin with. It gives you some theoretical background maybe, but you should never end with e-learning. You've done your e-learning, tick, you're now a perfect manual handler is not going to wash. You can use the e-learning or whatever, the videos, to get the theory across and then start practicing in person, boots on the ground. Let's trial out these things that they've said in the video and work them out together. Is that okay for that? Any more questions on that, Heather? Is that covered that one off? I'm going to carry on talking.
I think that covered that one off, to be fair. I think Martin was asking, you know, how you viewed the effectiveness of each method and whether the e-learning, online training versus the hands-on practice was the best way forward. So I think you've covered that.
Yeah, yeah.
So thank you.
Proportionality. So I work in an office. I don't do manual handling. I'm also a nerd and manual handling. So it may be proportional for me to do something that's very light touch, a bit of e-learning is maybe proportionate for me because I don't do manual handling. Just want to raise awareness. If you are doing manual handling as a task, though, then it needs to be proportionate. You've got to show people how to do those tasks safely. So proportionality, I'm not saying everyone has to get early manual handling trainers in all the time. If you work in an office, working somewhere low risk, don't worry too much about it. Let people know there's the pertinent things, maybe key risk factors, maybe where they go if they get a tweak or a twinge, how are we going to look after them? Which I guess is the next bit. But not everybody needs full-scale manual handling technique training. But those people who do manual handling as a job, they definitely do. The e-learning is not going to wash for them. Thank you for the question.
Thank you.
No matter how good you are at all this, even if you stop doing any sort of mechanical labour, first of all, please, for God's sake, don't stop doing manual handling and upper limbs intensive jobs. They're really important. Otherwise, the next hour you spend on a webinar like this is going to be the NHS, why are we all so fat hour? Because physical work is health promoting. It's very, very good for you. But even if you stop doing physical work, you're still going to have a workforce that's getting older and simply refusing to die. And so you're going to have to manage their well-being, um, and manage episodes of musculoskeletal disorders. The first thing would always commend to you is the back book or the upper limbs book, available from TSO Books. We didn't write it. We don't make a penny out of it. It's been around for 20 years, but it's still very, very good. Back Care do a similar book as well. Hop7 came out. If you're into healthcare, Hop7's out as of, let's say, earlier this year. And with Hop7, they've got leaflets that do a similar job to the back book. The idea of this is you thrust it in front of somebody as soon as they've got an injury, they've got a pain. It's really very profoundly well evidence-based and gives them really good health promoting guidance and advice on how to look after themselves post-injury. So first management is 50 pence each, I believe. Pass them out to anybody who's got an injury at work, your loved ones, get them to them before they go and see a GP and before they go and talk to their mate down the pub and get all the scary stuff from those people. Very affirmative and very much about health promotion. But then you look at how do we treat people? And thankfully, we've been making this up for ages. We get Occy Health and maybe a physio and so on and so forth, bone clickers and other professionals. Thankfully, back in the day, Public Health England looked at all the various methods for treatment for us on a really good report. And it was the biggest kind of consolidated look at, musculoskeletal disorders, post-injury management. And what they found was quite profound. They found, of all of myriad of solutions you can put in place, and we've looked at these, occupational health, straight to Occy Health, which is a good thing. For every pound you spend on Occy Health, you get about £2 to £3 back. It used to be for every pound, Agpo did this, the physiotherapist, for every pound you spend on a physiotherapist, you get about £4 return on investment because you get people back to work sooner and healthier sooner. All of it was made up, all of it was rubbish until Public Health England came along. And what they found was getting people to a physiotherapist as soon as you possibly can. So every pound you spend on having that facility, whether it's in-house physio for a large organisation or access to physio through your health providers or something, if you can get them to a physio, for every pound you spend on that intervention, you save about £98 in reduced losses. So lost time injuries and management time, those sorts of things. Huge cost saving and also morally the right thing to do. People have less severe pain, have less duration of pain, get back to work quicker because of good medical-based advice. So commended to you if you're having a rubbish weekend already, crack on and read that one. But take my word for it, it looks at lots of these interventions and finds that fast access to physiotherapy is the most cost-effective way of looking after people when they've had a musculoskeletal disorder. Thankfully, it's also morally the right thing to do as well, which is nice when those two things line up, isn't it? And then finally, carry out regular checks of effectiveness just to see if what you're doing is correct. Annual reviews, or we already mentioned this, maybe the NMQ, the Nordic Musculoskeletal Questionnaire, and so forth. Right, quickly put your sandwich down and take a screenshot of that. There are all the links to the various things I've been talking about, the body map at the top, those Washington State ergonomic ideas on the right, and then at the bottom there, the link to the website for the HSC MSD Design Awards. I've got 10 minutes left and one more slide. So hopefully you're still with me. I'm going to show you one last thing. I'm not moving away from MSDs, but there's one thing that, in case I'm having a wild guess, because you've decided to come on an hour-long thing with me on MSDs, it might be that you're just interested in DSC and display screen equipment. And if you are, this is for you. Because last slide, earlier this year in June, we produced a research report RR1205. And if you go on our website and search for RR1205, RR Research Report 1205, you'll find this. I did have the title, but it's got such a ridiculous long title, it took up the whole slide. So I've not given you the title, but RR1205 will find you this report from our website. And it's been a review of the MSD risks related to DSC. Post-Brexit, we have the opportunity to decide to go a different direction with our DSC regulations. That's all kind of anchored to a European directive. We got the choice. Should we do something else now? What's the evidence base for the European directive? There isn't one, really, back in 1992. And it's very fair to criticise HSE for the DSE guidance we have in print. We're much better online, but the print guidance has long since passed its best. But since 1992, when the DSE regs were written, technology has moved on significantly. But is it effective? All those new things. I'm at a very cool standing desk at the moment, which is kind of nice. Is it working for me? Does it have an impact on it? And does this provision of all this kit actually help? It's been a huge renewed interest in DSC, display screen equipment, office working, post COVID, when we were sent everyone home to work on their kitchen tables. Can I just say, when we're looking at MSD stats, working on these tables, we thought we'd get a huge increase in musculoskeletal disorders. We didn't over COVID. And that is heartfelt congratulations to whoever's on this webinar that spent time trying to re-engage our workforces in display screen equipment. It worked. We haven't had a huge impact because we're compromising. And largely that's because of all that stuff we were sending out, including equipment. It seems to have had the desired effect. So very well done you. But it has created a renewed interest in DSE. So we did a rapid evidence assessment. So an REA, which is a formal evidence review, if you like, looking at all the peer-reviewed studies, all the research you could find for about a 40-year period on DSC related health topics. It's a riveting read. It's on there on the website. I'm not going to go into all of it. A guy called Lamre Okunrabido, one of our PhD colleagues in my team, did this. And what it showed was there are associations with display screen equipment and musculoskeletal disorders, back pain and bloom disorders, and even temporal visual fatigue, eye dryness, headaches, eye soreness, and things like that. Really importantly, it didn't find any evidence to suggest that you get prolonged eye problems from looking at screens. There's never been a case, as far as we're aware, and all the issues we have with eyes is related to the reduced blink rate, more dryness. And so you go to bed at night, wake up the following morning, they've recovered. But he did find moderate evidence between, these kind of back pain, upper limb disorders and visual issues for various factors like prolonged DSC use, how many hours a day you're working on computers, workstation design and posture. And if you're compromising your posture, it's your workstation, insufficient breaks and things like that. We also found that the provision of equipment is doing a lot of heavy lifting for us. We can set up stuff pretty much how we like it in front of you. If any of you are working on a sofa right now looking at a laptop, or voy, if the doorbell rings now, that's HSE calling because we don't like that. If that worked for someone, that would have been a terrifying moment, wouldn't it? But maybe not. So we know, though, that on desks and half-decent workstations, that setup is really important. We've got the facilities and the equipment to set things up however you want. So a lot of the emphasis is going to be on looking at enhanced workstation design standards, looking at informing people about their posture and getting that kind of engagement going. I don't think for a minute that the DSE regulations are going to be rewritten in any way that anybody would recognize. A few words here and there maybe, but the DSE regs are probably going to stay. The guidance is going to be updated, probably not published in a book because they go out of date immediately, probably online, and provide DSE guidance in that kind of format. It was the big news last summer until Roy had an election and things changed a little bit this year. But we're ready and we're poised and we're about to start looking at IDSE guidance on the back of this big review. So again, it's 100 odd pages long. I'm told, I'm reliably informed, it starts getting interesting when about page 20. But do feel free to download it and have a read and queue yourselves up. And that's me done. I've left exactly 4 minutes for questions. But we've answered some. But any questions at all about anything I've mentioned or anything else? If I don't know, I can easily say I don't know. I'm not bothered about that. Please feel free to share any questions. And I'll stop sharing, shall I, before anybody actually writes down my email address and learns out how you can get hold of me.
I do have another question for you here, Matt. And this was from Aspen again, and it was, the pharmaceutical industry use tools like REBA, REBA, and RULA, RULA, for economic assessments. And are there any notable differences or advantages in using the tools recommended by the HSE for MSD risk management, or for using the tools that they have in place already?
Yeah, thanks. Reba and Ruler are Ruler was first, Macatomy, and then Reba was an addition or an expansion of. So Ruler, rapid upper limb assessment, and Reba, rapid entire body assessment. Reba just looks at your legs as well, which is not necessarily a bad thing, especially if you're compromising your lower limb posture. The perhaps issue, and I say perhaps, there's no evidence for this other than practitioner feedback, me being one of those practitioners, is that Reeb and Ruler, because of the nature of the way they're at, they focus on posture. And they've got lots of different imagery of posture, which looks and forces the assessor to look at each of the joint angles as you go through them. And there's absolutely nothing wrong with that at all. What I think it is very, very useful. What we try to do with the ARC tool, which is its equivalent, is have a slightly more balanced tool that takes into a bit more consideration, yes, posture, but also repetition and force, which Reba and Ruler do. But we've tried to just emphasize that a little bit. And then other factors, are you wearing gloves that make grip hard, or do you hate your boss, or those sorts of things. So the art tool was made on the back of Ruler, and no, the Reba and Ruler perfectly acceptable. It'd be really funny to watch your regulatory colleagues see that you've used them, and they'll go, oh, "What do I do with this?" They'll phone us. Nothing wrong with them whatsoever. We just think in normal practitioner, sort of non-ergonomist, health and safety expert, we thought that those tools focused a bit too much on posture and not the other sort of risk factors too. When we validated the ARC tool, we validated it against Ruler. So if you score high risk on Ruler, you will score high risk on the ARC tool and vice versa. So they do work very well together. But if you're using one, you don't need to use the other.
Okay, that's brilliant. Very informative. I think the other questions that we've had in, we've asked as we've been going through. There's some thanks coming through as well on the chat now from some of the participants, so that's very nice. The recording, this presentation has been recorded today, and that will be available to members of IIRSM on the resource hub. So if you are looking for some information that you maybe didn't catch in time, then that will be available on there for you as this recording. I think Matt left his email up there long enough for you to just grab that if you needed it. I'm sure that was there. I'm sure you've got a screenshot from there. And I'd just like to say thank you as well. I've taken quite a few notes as we've been going through, and I've taken some screenshots of those QR codes as well that I'll be sharing with my colleagues and with clients as well. So that's been really useful and very beneficial. So thank you very much for your time today, Matt. I'm not seeing any more questions come through at the moment, but like I say, if anybody does have them, just forward them on to myself, or if you got Matt's email, then do that as well. That's fine. But thank you to the participants for joining, and much thanks to yourself, Matt, for the really informative presentation that you've given today. Thank you so much.
My privilege. Thank you, guys.